Welcome everyone to today's webinar, Revenue Changes for Laboratories in 2021. I'm Richa Singh, Executive Vice President for CollectorX, and today we'll be hearing from one of our partners, Mick Raich, CEO of Vachette and Stark Medical Auditing. We'll begin today's webinar with a presentation, and we'll have time afterwards for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We're looking forward to hearing your questions, but if we're not able to cover them in today's session, we will have someone reach out to you afterwards to answer them directly. Now, today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. So for today's presentation, we'll start with a brief introduction to CollectorX and Vachette. After that, we'll discuss the challenges that we're seeing with labs across the industry and with our clients in particular in 2021. And then we'll take a look at our out-of-network payment trends, and we'll wrap up with a discussion about the 2021 surprise billing legislation. So let's first off start with some introductions. Mick, would you like to go first?
Yeah, I'm Mick Raich. I'm the president of Vachette Pathology and Stark Medical Auditing. I've been doing this about 19 years, and this is probably the most dynamic year of my life when it comes to the revenue cycle world. There's been so many changes, so many new government rules, and then literally the volume of testing this year versus any other year is exponentially larger. So it's an interesting time. I'm glad to be here to work with you on this and to chat and to discuss my thoughts going forward. And I look forward to hearing your information also.
Great, thank you so much, Mick. So if we can advance one more slide, please, and we'll talk a little bit about CollectorX and why we're in the position to talk about payer collections. Simply put, what we do here at CollectorX is we help providers get higher reimbursements on in and out of network bills and maximize payer collections. We don't do this as consultants, but as experts in negotiating and appealing in order to achieve higher reimbursements on your bills and collections. Now, we were founded by the founders of the out-of-network negotiations and appeal industry. We've been singularly focused on helping providers get higher reimbursements since 2006, and we've helped more than 2,500 providers nationwide optimize their reimbursements on in and out-of-network collections. Now, we work with a variety of provider types, including surgery centers, hospitals, and of course, labs. But the reason that we get the results that we do is, one, we rely on CRIXIS, which stands for the CollectorX Information Systems. This is a proprietary data and analytics tool that we've developed to support as we go toe-to-toe with payers. CRIXIS helps us analyze insurance policies from across the states. It provides us with comparable reimbursement data, and it allows us to track the tendencies and trends of the people on the insurance company side. But in addition to CRIXIS, we also rely on our expertise. We've built a unique team of experts who used to work for the insurance companies and their vendors, companies like the ones that you see on this slide. So Aetna, United Healthcare, MultiPlan, and Viant. We also have doctors and in-house and outside legal experts, many of whom have spent their entire career dealing specifically with out-of-network bills. So as a result, CollectorX has an experienced team that understands how to combat the tactics payers use to limit out-of-network reimbursements. So with that introduction, let me hand it back over to Mick to go through some trends that we're seeing at the macro level. Mick?
All right, thank you very much. I'm going to talk a couple different things. First, I'm going to talk about COVID in the government. We want to look at the concept of, where's COVID billing going? What's going on there? Where do we see this coming forward? I did read a publication here last week that said COVID testing is actually going down, and the good news is the positive number of positive tests is actually going down. The question is, going forward, if we put $900 billion in this in December of last year, and we're going to put $1.9 trillion in the next stimulus package towards it, that stimulus package has 800 amendments to it, by the way. The question is, you ask yourself, is COVID testing going away? Are we reaching a point where this type of issue is going to change and be done with? And I would ask you to look at the narrative. The narrative very clearly says this: If you look at Google, they do 40,000 searches a second. They're 72% of all searches in the world take place on 76% take place on Google. And their number one search in 2020 was coronavirus. Their number one search on news was coronavirus. Now, Twitter is a different story. Twitter did some research there. Their number one hashtag was COVID-19 last year, but number two was Tiger King. So there is hope for us. So that's where the narrative is right now. The narrative also on COVID was, back in April, May last year, it was look at all the deaths and the hospitalizations. And then over the summer, it was the narrative about, the workers being overstressed and overwhelmed. Then we had that little spike in November where everything went back up and everyone was worried about hospitals being overwhelmed again. And now we're talking about the different variants, the B1.351 virus, the B1.1.7 virus, the P1 virus, all these different variants of COVID that people are worried about going forward. So the question is, will that narrative change, or will people continue to move on that? And then we also have to ask ourselves, there's a series of mysteries out there that are going to be left unanswered until we get further direction from the government. For example, the screening test and the collection fees. There's a lot of different rules out there. The government seems to be stressing us to test every person all the time, but it's very clear that you can't test every person all the time without some medical direction or without medical necessity and without exposure. So then we look at payments when it comes to these screening tests and collection fees and who can actually do a collection fee and who can't. There's some gray areas there. There's also big mysteries on what are the options if people don't pay for COVID claims. You're supposed to, during a public health emergency, you're supposed to not balance bill the patient for copay deductibles, yet we have insurances pushing that. And we're seeing more and more people actually pushing, more insurance companies pushing this away and saying, no, you have to balance bill. We have to ask ourselves, when does the public health emergency end? And when that ends, how does that affect the timely filing extension that's currently in place? Interesting rules there. We have to ask ourselves, when does COVID payment change? Will July with the new Medicare fee schedule, will that propose a new payment rate for COVID? That could be very interesting. But the thing we want to work most with today is the concept of these denials. And that's where Richa and her team comes in, and they have this unique solution that I think many, many labs are going to be digging into, especially as we look at a further billing of insurances going forward, and we're going to see much more denials going forward. So back to you, Richa.
All right, thank you so much, Mick. I appreciate it. It's a lot of good information. Obviously, COVID is a hot topic, so thank you for putting out there what you've been seeing. And now we'll take a turn and jump to out-of-network payments in general for labs. So what are we seeing in out-of-network? Well, there are really 5 big areas that we're seeing that impact labs. So we'll start with the first and maybe the most obvious one, which is challenges with coverage. So one recent issue with the pandemic is there has been a decrease in health coverage due to the increase in unemployment. Also, as a way to cut costs, employer groups have been changing their plans, which causes confusion on who's paying for what testing and vaccination charges and what's included in the individual plans. Next, what we're seeing is a significant increase in denial rates. Now, based on Xifin's data, early on in the pandemic, payers had around a 22% improper denial rate. This has been managed with most of the payers and is down to about 8%, half of which can still be resolved with a phone call, but the other half is going to have to go through an appeals process, which we'll get into later. However, data also from Xifin shows that some payers continue to charge copays and deductibles and deny eligible COVID-19 related claims, particularly for the serology test for antibodies. Now, the challenge of getting the highest reimbursement possible for your charges has never been more daunting. Even prior to the current challenges of COVID-19, the payers and insurance companies have executed a campaign to reduce payments for as many encounters as possible. So this slide shows how that plan is executed. Payers continue to challenge providers through revenue leakage in the form of denials. The additional work required to resolve or respond to these deductions have forced many billing and collection operations to consider how or whether to address it. Is there value in paying attention to your denials? We really say that there's no choice but to do so. And many billing operations that we deal with across the country share the key reasons why appeals of denials often go unaddressed. Many times it leads to low cash flow and in some cases reduction in operations. So we've heard, the appeals process is just so complex. It's expensive, and it is. Denied claims appeals cost over $8.6 billion annually. A lot of major reason that we hear is that a lot of providers simply have a lack of time, and most importantly, probably, is a lack of expertise. So how are the payers denying these claims? The first thing to know is that payers are always looking for ways to control costs, meaning the amount that they pay out to providers. So one strategy the insurance companies use is the outsourcing of bill minimization tactics to third-party vendors that specialize in helping payers reduce payments to providers through two main ways. One is through upfront negotiations that you may have seen, and the other is through repricing the bill. Now, you may have heard of the companies like MultiPlan, Viant, and CN. It's vital to understand that these are cost containment companies that are employed by the insurance industry to reduce payments to providers. So do yourself a favor and venture out on their websites of these companies. You'll see it all laid out right there. Their goal is to maximize the discount. And the reason why is because that's how they make their money. The vendors are compensated on a commission basis. So the greater the discount, the higher the commission that they receive. So let me turn now and spend some time discussing the trends in payer tactics when it comes to denials, underpayments, and delays. The first trend I want to discuss is that payers are not paying claims based on the summary plan documents. So you might know a summary plan document is the agreement between the employer group and the payer. That's fine. The document specifies how the claim should be paid if the member goes to an out-of-network provider. So instead of following the document, a payer may use a repricing company, and how that repricing company reprices the claim is the gray area. They could be using Medicare plus a percentage, or even though the summary plan document states that the claims are going to be reimbursed at usual and customary. So when the claims are repriced, the EOBs are misleading, both to the member and to you as the provider. Second trend that we're seeing is repricing inconsistently for the same codes. And I'm sure you see this and just makes you want to pull out your hair. We see it so frequently with payers like Cigna, United, Aetna. You have the same codes billed for multiple patients, and the payer allows different rates for each patient. So for example, you have a patient, comes for a test, claims paid by United Healthcare at X dollars. Next day, another patient comes in, same test, United Healthcare now pays at Y dollars. How can the same code be allowed at different rates in different ways? In the opposite direction, we've even seen it. We've seen that codes allow or pay out the same exact amount for different providers in different states. So at times, the pricing methodology just seems to be so random. Now, the third trend is that so many different types of pricing methodologies, that there are so many out there that even the payers don't understand it. So Aetna is a perfect example. This is why they also don't want to have to provide summary plan documents, and they make it difficult. They have a hierarchy of pricing methodologies that are loaded into their claim system, and it depends on whether the claim is manually priced by a processor or auto-adjudicated, and which pricing they actually use completely disregards the plan document. Fourth trend, leveraging their special investigation unit to not pay claims if the patients aren't billed. The payers are more and more utilizing SIUs, which are departments dedicated to investigating claims and patient balance billing. They'll actually reach out to the member either by phone or by correspondence asking if they've been billed. And the payers will deny claims, sometimes outright, or they'll make a small token payment. Then they'll ask you to submit proof of a patient payment. So basically, they're just asking you to adjust off that claim. Now, the fifth trend, multi-layered approach to repricing companies. That's a lot to unpack, so let me simplify it. What we're seeing specifically from one payer is that we often receive negotiation requests from companies like MultiPlan, we see the allowables topping out at very low amounts. For example, where we are typically able to negotiate 90 to 100%, we're getting closer to 30 or 40%. And the claim then goes back to reprocess on the payer side, gets an initial payment, but then it gets filtered again through a second silent PPO. The good thing about this is that we can identify these claims and then initiate the negotiation process a second time to push those allowables back into the 90th percentile. A lack of managed care contracts continues to be an issue for labs. Pathology, for example, continues to be one of the highest out-of-network specialties. And skinny networks that limit the amount of providers available in certain networks, they are most prevalent in the lab space. In terms of network adequacy, there are few requirements for payers to verify that plans include enough in-network service providers when offering plans to consumers. Experts blame insurance regulators for not ensuring the adequacy of healthcare networks that include hospital-based physicians, like pathologists and radiologists. Insurance regulators can do more to certify network adequacy, meaning that health insurers maintain sufficient numbers of in-network physicians and other providers in the plans they market to consumers. As such, requiring adequate networks of physicians and health plans will reduce patient costs by ensuring in-network services are reasonably available. The big three payers have implemented a preferred provider network designed to lower costs, they shorten wait times, and they improve patient outcomes. While they still maintain their in-network provider network, the writing is on the wall. So what can you do? You can keep a strong referral base, market how you're managing out of network, and consider in-network with specific plans for strategic purposes. So for instance, looking at smaller boutique insurers and specific employer groups. Now let's turn to some of the best practices that we're seeing to counteract growing volume, increasing denials, more underpayments, and even more delays in processing that results in cash flow issues. Now, in terms of billing and collections, lab revenue cycle systems, particularly those that are part of larger hospital systems, are not the best fit for payer collections. You need a specialty system that will ensure that you don't overlook follow-up, stay on top of denials and potential delays. EDIs are critical. You need to maximize electronic billing. For medical record submissions, you can always electronically submit them through the payer portals, or you have the ability to do so with some of the payers. We have a client, for instance, who came to us entirely paper-based in order to get medical records attached to every submission, but that was hugely delaying their payments. So to increase speed to first payments, EDIs make your payments much faster. Consider outsourcing to a vendor who understands out-of-network and will let you scale. Everybody has huge correspondence teams that are working with payer delay items that may come back. So you have to have these teams. If you're only staffed to bill, you're done because you'll miss timely filing. Outsourcing lets you flex this based upon your needs. And you need expertise in out-of-network. Even more importantly, you need the data for out-of-network. You also need to focus on collecting from payers, not patients, simply because one, patients have less disposable income, and of course, payers have more. You need to make sure that you're collecting from the payers what you're entitled to. And there's multiple keys to lab billing. So for instance, ensure the integrity of your medical records are intact, because if you're not documenting, they're not paying. Identify those tests that require authorization. Work with billing companies or systems that can handle your volume and your complexity with a focus on payer collections. You also want to understand out-of-network intimately. And finally, follow up and work your payer delays, because compared to other specialties, for labs, payers rarely outright deny, but they make you prove service and they time you out, in which case it becomes a denial. Okay, so now let's turn to best practices in revenue cycles, specifically for out-of-network providers. So what's the most important step? It is to focus your attention on AR and payer collections. So you want to set a goal and meet it. Then you want to change your goals as a percentage of billed charges as volume fluctuates. You must know what's owed to you and expect that it's going to take longer to collect because it is out of network. When you can, verify benefits. As I mentioned earlier, people are getting laid off, they forget to COBRA, and they don't have coverage. Even if they have insurance, they may not have out-of-network benefits. Consider if there needs to be any type of financial counseling to provide. Verify the specific plans up front if you can. Is it self-funded? If it's a Cigna case, is it MRC1 or MRC2? Third best practice is to appeal out-of-network underpayments and denials. Up to 40% of laboratory claims are known to have missing or inaccurate information, which leads to delays, denials, and oftentimes write-offs. CMS statistics indicate that only about half of denied claims are ever returned for processing. So one way you can increase your collections is by ensuring that you're appealing all out-of-network underpayments and denials. Because as we noted earlier, denials, they're at an all-time high, and you have to appeal if you want to maintain your collections. Leveraging technology. So analyzing claims is extremely challenging when you're using your billing system alone or you're using manual approaches. When you use technology to help manage the payer reimbursement process, you're able to do more with less. Automated data and analytics allows you to quickly identify and prioritize at-risk accounts before they become a problem. Then you can leverage workflow technology to assign a path for each claim, therefore ensuring that nothing falls through the cracks or is missed due to oversight. Bots are automated agents that scan payer websites and automatically update you about the status of payments. Feeding account statuses eliminates the need to follow up every 7, 10, or 14 days because the bots are continuously pinging payer websites. This ensures you get statuses even before you receive the 835, making your staff more proactive in working your accounts. Using bots can ensure your team is making the proper touch at the proper time, and there are many vendors out in this space that can help you set this up. Just keep in mind that you need to ensure the bots are driving workflow, not just bringing back the data. And a moment on centralized data, it's very important to have all your data in one place talking to each other. Everything from your billing system to your clearinghouse to payer websites and workflow tools, everything should be automatically pulled into one place. Having your collectors work out of that one primary system that has all the data will also help you streamline processes and their effectiveness. Having data is important, but automation is the key. Think about how many collectors it would take to do all of this manually. And one more way that I'm just thinking of with technology is that it can help increase your collection rate by leveraging workflow automation, because understanding workflow is critical because the most common issues on the back end of your collections are caused by breakdowns in the early parts of the revenue cycle. So things like incorrect claim data. You need to dissect your workflow and identify weak leaks on the front end in order to help increase cash flow and reduce aged AR on the back end. More specifically, when it comes to revenue cycle best practices, let's spend a moment here on how to win your appeals. First off, reading and understanding your EOBs is a major factor. This is easier said than done, as EOBs are often difficult to decipher by design. If there's one takeaway from today, it's to check your EOBs, because if you don't, frankly, you're losing money. And with high volume, using bots to pull in and organize that information will be much, much faster. Now, when the vendors opt to settle a case through negotiations, they do so by sending proposals that often have short turnaround times for a response. Their goal is to put pressure on the provider to settle quickly. Sometimes those turnaround times are real, but sometimes they aren't. Third-party contracts. This is incredibly important as many labs enter into them to help manage their high volume. The vendors sell these contracts to providers that promise great rates. The catch here, though, and what they don't want you to know, is they're applying various cuts such as usual and customary. So many times your final rate is just a fraction of what you thought it would be. Of course, that is if you check. Many providers don't even track their payments to see whether they've been paid correctly or not. I remember one of our providers, they came to us and they said, no, we've got this great contract. It's for 90% of billed charges. And I'm thinking in my head, there's no way. So he sent over the contract and it actually said it's 90% of eligible charges, not billed charges. That eligible charges gave the insurance companies leeway to cut what is quote unquote eligible and then take 90% of that. So we did a review for him and it turns out that that 90% contract he thought he had, he was only getting 37% of charges. So remember, these vendors, they work on behalf of the insurance companies to save them money by reducing payments to you. Knowing that any contract you sign with them is really a cap to your reimbursements and a saving to the payers. All right, so now let me finally spend the last couple minutes on the surprise billing legislation, which just came out. And I want to talk about first off, what's the good and what's the bad of it? We'll start with the bad. Out-of-network clinical laboratories may no longer be allowed to bill patients for lab tests, and patients pay only deductibles and copayment amounts that would normally pay for in-network care under their health plan. But for the good, it really greatly applies to emergency care or care provided for in-network facilities by an out-of-network provider. There are only 18 states without balanced billing laws, so odds are you're encountering some of them now. Clinical labs and AP groups that still have payment disputes with consumers would need to negotiate acceptable terms with insurers. Now, after initial opposition and months of legislative wrangling, organizations representing medical laboratories and clinical pathologists have expressed support for new federal legislation that aims to protect patients from surprise medical bills, including for clinical pathology and anatomic pathology services. And the law permits balanced billing under some circumstances, but only if the patient gives advance consent. And some specialties, including pathologists, are barred entirely from balanced billing. The law also establishes a process for determining how healthcare providers are reimbursed when a patient receives out-of-network care. The specifics of that process proved to be a major sticking point for providers. In states that have their own surprise billing protections, payments will generally be determined by state law. Otherwise, payers and providers have 30 days to negotiate payments. If they can't agree, payment will be determined by an arbiter as part of an independent dispute resolution. So for example, if someone goes to a hospital and doesn't have a choice of who gives them anesthesia, or the pathologist who processed their lab work, or the radiologist who reads their x-ray, or other diagnostic tests, patients cannot be balance billed because someone turns out to be an out-of-network provider. One exception to this provision would be if the provider lets a patient know 72 hours before providing the care that the provider is out of the patient's network and the patient consents to such care. And of course, also the extra charges that go with it. Clinical laboratories, pathologists, radiologists, assistant surgeons, however, would not be allowed to seek consent to balance bill for their services. What's more is the legislation allows the consent seeking process only in non-emergency circumstances. So what you can do to prepare is establish processes to end balance billing. First and foremost, especially if you're not in a state that's already has balanced billing protections, you need to establish a process to make sure that patients are not balance billed, but don't expect that it won't extend to all procedures sometimes in the future. Get ready to provide estimates as well. Providers have to prepare to give patients a true and honest cost estimate because otherwise there can be monetary penalties involved for non-compliance. Remember that arbitration costs money, so providers need to consider their dispute resolution options. Disputing parties have the option as well to resolve these payment disputes for out-of-network bills offline. And finally, pay attention to the details. Although the No Surprise Act was signed into law, more details are still coming. So for example, The Commonwealth Fund notes that federal officials will have to establish a list of eligible arbitrators and help interpret the factors that will guide arbitrators' decisions. So there still is a rulemaking period that must take place between the passage of the law and when it actually takes effect. But we know the text of the law, but not the intricate details of how the law will be enacted. Okay, so as we go through 2021, chances are you'll run into some of these trends in out-of-network payer tactics. And when you do so, just remember that you have plenty of tools in your toolbox to combat them. The best way to combat them is to be prepared. And I hope we've been able to provide some good information that you can use in your daily practice to ensure that you're getting paid equitably by the payers, also that you're getting paid in a timely manner and that your claims are not being denied unfairly. Out of network is a good strategy for many labs, and we hope that we've been able to help you integrate some of these factors into your daily processes. So I want to thank Mick again, but I think we might, I know that we're going over, we have a couple, let's just ask a couple questions or take a couple questions before we jump off. How can we avoid the special investigation unit is the question. Okay, so you can avoid the special investigation unit. Well, let me back it up. So SIUs, they're often triggered when there's absolutely nothing collected up front. If you do balance bill, you have to attempt to collect something up front, so long as you show that you did something, that you've made some sort of good faith effort, upfront effort. And we can argue that our providers are balance billing or collecting so long as they are collecting something up front. I mean, even $20. But it doesn't work anymore to just send a bill out. You have to show that you actually collected the payment. So hope that helps on that. And another question, what are some of the most common denials you're seeing and how can we avoid them? Some of the things that you have to watch out for, well, first off, making sure everything is as clean as possible on the front end is probably one of the biggest helps to, eliminating the denials on the back end. But some specific things would be, looking out for, some CPT codes that just aren't covered. So make sure that it is correct and that you're able to bill for it. Make sure you're collecting the right information up front because that can be causing billing errors. And then access the clinical bulletins on each payer website to make sure that, the codes are approved. All right, so again, we went over, but I appreciate you all for sticking around. Again, I hope that this helped and that you're able to incorporate some of this into your daily lives. And thank you, Mick, for your excellent presentation. I think it's information that everybody needs and wants to know right now. So once again, enjoy the rest of your day, and we look forward to having you join us for future webinars. Thanks, everyone.
Thank you.